Regenesis Open Education.
And with this, I'd like to thank you all. And I hope I did not go over. I was very close to going over, but I hope it did not go over. If you do have any questions, please feel free to ask me, or please feel free to reach out to me on any of my social media handles. And I guess I'm here for you. I don't know for how long, Jane, but I'm all set. I'm all done.
Okay, thank you so much, Professor Galadari, for such a detailed presentations, thorough. And what I have learned so far from your lecture, your presentation just now, is that have our hyaluronidase near us. Other than that, have Viagra and your ophthalmologist friend near you all the time. Okay, so we have some questions coming in the question and answer box. So there, I will ask the questions that is related to our topic today, which is about complications. So coming from Dr. Jessica Stephanie Sudarso, hi, Professor Hassan. Thank you for the super detailed explanation. So she was asking, is there any golden hour for vascular complications for us to inject hyaluronidase to decrease the complication risk? Or if in 24 hours after injection of fillers, the patient doesn't have any complaints, does that mean that we are safe? Thank you.
Yeah, that's a good question. So there is no actual golden hour, but the sooner the better. So if the patient, you realize that you've had a vascular or a likely vascular event happening for you, you need to take care of the patient as soon as possible. So that's a given thing. And then, also that being said, if you treat them, you also want to make sure that you follow the patient up, because they may look normal to you as they're going out, but then the process could still be going on as they're walking outside the door. So you want to make sure that you have to ask them to come back and see you, for example, in about the next day, to make sure that if necessary, further hyaluronidase should be injected.
So would you ask how long would you ask your patients to wait and after injections in your clinic to have like observations after injections?
So, well, I mean, okay, so when you finish the injection, and if you know that anatomically everything's okay, there's no pain, everything's fine, patients can leave immediately. I don't ask them to stay.
Okay.
But if the patient, I've noticed that there's blanching, the patient is complaining of excessive pain, I would ask them to stay for at least, anywhere between 30 minutes to about 45 minutes. And if the pain is not subsiding, then I would need to kind of look into it even further. If it goes away, then I can, you can basically tell them it's completely okay, but you have to actively contact the patient. So for example, I give them the clinic WhatsApp number, and the clinic would call them and contact them, just making sure that they're okay. And I would tell them that there is a chance that we might have an adverse event, and I want you to take a picture of, and I show them the area. I want you to take a picture of the area that I injected, and I want you to send pictures to me on a regular basis.
Okay, so you mean that you will ask the patients to take pictures of themselves the next day and after the injections, and send it to you to make sure that he or she doesn't develop anything. Okay, I think that's a good tips for us doctors. So tell the patients to take pictures. And would you tell the patients the signs that they should be aware of?
Well, I mean, if they start seeing the signs, I don't want to say it's too late, but I don't want to scare them off. So I mean, the most important thing is the most important sign is going to be pain. So if the pain is persistent, if the pain is not going away, that's the time in which I need to see them back, or it's something very important. I would also tell them if there is any discoloration, and if especially the discoloration, and it's difficult for the patient to know if it's what is web-like, what is reticulated versus, for example, a simple bruise. So that's the reason why I would ask them to take a picture, and then I would be the one who would kind of be able to tell whether this is a reticulated change that's happening because of vascular compromise, or it could just be just a regular bruise that's occurring on a patient.
Okay. And then let's go to the next question from Dr. Ubeta. So Dr. Ubeta is asking about this dosage and the time of injecting hyaluronidase to prevent necrosis complications. So is the dose for several areas is going to be different or accustomed to the degree of the signs of impending necrosis?
Yeah, it's a little bit of both. I mean, sometimes also the amount of product that was injected. So personally, I mean, I know there's a publication out there that tells you this. For example, for each 0.1 ml, how many units needs to be injected. Personally, if I see a complication happening in front of my eyes, I'm not going to remember what the exact dose. All I'm going to do is I'm just going to flush everything out. Okay, so I would use, anywhere between nearly 500 units at one go, and then have the patient stay and visualize the area to see if if they're getting better. If they're not getting better, then do the exact same thing. I would just want to, for me here, science is important, but you just want to make sure that everything is completely gone.
Okay, so this question is similar with Dr. Rani's question about injecting the hyaluronidase at the entry point or as much as the blanching area. So all.
The whole area. Yes, absolutely. So you want to make sure that the whole area. So you do inject the area where you've injected the original area, but then you also want to make sure that the whole area is also reperfused with a little bit of hyaluronidase there too.
Okay. So since we are talking about hyaluronidase, there's one question asking about the hyaluronidase after we have reconstituted. Can we keep it or we should throw it away?
No, I usually keep mine. I put it in the fridge and it works completely fine.
Okay, so just keep it in the fridge. How long can we keep it?
That's also another good question. So it all depends. I mean, the manufacturer will tell you that it's a one-time use only. But I mean, personally, in my experience, I mean, I've kept it for anywhere between 2 to 3 weeks, and then after that, if it's not being used, I would throw it away.
Okay, so 2 to 3 weeks, and you can keep it safe in the fridge as long as you are sure that it is clean. You have to keep hygiene.
Exactly. So it's very important not to open the cap. You see, because remember, if it's, I don't know what hyaluronidase is being used, but if the vacuum seal is tampered, you've opened it and you've removed the rubber, you have to get rid of it. But if the rubber cap is still sealed there, and it's vacuum sealed, you can keep it for about 2 weeks. But that's the thing. So make sure that you don't remove the rubber cap.
Okay. So the next question is about aspiration. Cannula, aspiration, and should we stop? So the first question coming from, and I'm so sorry, he or she doesn't write down their name. So if we use cannula, should we aspirate before we inject?
No.
Is there any use to aspirate with cannula?
There is no, well, I'm being recorded here, but I'm going to say, I mean, there's no use to aspirate even with a needle.
Okay, because what I was aware that it stated that only 30% of positive aspiration is like really positive, like 70% might be intravascular, but we are not aspirating it.
Exactly.
Yeah.
So for me, moving is much better than aspirating.
Yeah, and also to be able to identify the signs of vascular incidence is very, very important. Like you mentioned, the patient would feel pain and then blanching. So I think it is very important to understand, to recognize the initial signs of complications. And so there's another question coming from Dr. Henry Tanojo. What are the essential key points in handling vascular complications after non-surgical rhinoplasty with filler? What are the basics do and don'ts in doing nose filler augmentation? Because in Indonesia, there are a lot of patients asking for nose filler augmentations.
All right. I remember telling this story, and I don't remember if I told this story to my Indonesian colleagues in the past, but I remember I usually tell the story of something that has happened to me, of a patient who came to see me who's had post rhinoplasty, and she had 3 rhinoplasties in the past. She came in and saw me, and there was a little bit of a slight depression on her nose that she wanted it to be corrected. And when you have a person who's had 3 rhinoplasties, the anatomy has changed. And this was for me a red flag, and I did not want to inject her, but she was very, very pushy. And she wanted to kind of say, she really made me or pushed me into doing it. So whenever it is that I inject, I usually use a cannula over a needle. And I put in my cannula inside, and the cannula would not move. And it's because of just too much fibrosis that was happening there. So this was the second red flag, saying that don't inject her. She's got 3 rhinoplasties, cannula is not moving, don't inject. But, given the fact that she was extremely pushy, and not just also she was pushy, and this is hopefully a message for everybody to learn, is that she was also kind of showing up my ego. She was like, yo, you're the best doctor in the world. You're like this, you're very famous, you're there, So she really boosted up my ego. So I switched my cannula to that of a needle. And then as I was injecting, she looked completely fine. And then by the end of it, just as I was coming out, all of a sudden her nose just blanches in front of me. So the take-home message here, if you are going to be injecting, really know your limits and learn to say no to your patients. And if you've got number of things that are going against the fact for you to inject, don't inject. Don't feel pressured to inject. Fortunately, with this patient here, we avoided any complications because it happened right in front of me. But then, these things can definitely happen with anybody who may not even realize that there is a problem, and the patient walks the door, and then you end up with devastating results. So if a patient has post-rhinoplasty, stick to the use of a cannula if you are going to be doing it. And if your cannula does not move, stop and tell the patient that you are unable to continue for their own benefit.
So what is the size of the cannula you are using for nose filler augmentation?
Yeah, I use a 25. I'm moving towards a 22 because, believe it or not, I had also another vascular event using a 25 gauge cannula for the lips. A patient who I was injecting for the lips with a 25 gauge cannula developed a vascular compromise. Now, this patient developed it because she's had fillers in the past. So I believe that the old filler that she had kind of pushed her labial artery and changed the anatomy. So when I introduced my cannula was going into the actual labial artery. So that's how it happened. But these things can happen with your cannulas too. So you want to be very careful and be able to identify those things from, once they happen.
Okay. Professor Hassan Galadari, before we proceed with the next questions, please let me speak also in Bahasa Indonesia to my colleagues here. So I will be bilingual. Oke, so jadi tadi untuk untuk pertanyaan mengenai kanula, apakah perlu diaspirasi atau tidak, tentunya tidak perlu diaspirasi. Bahkan dengan menggunakan jarum pun aspirasi negatif belum tentu betul-betul negatif, karena memang ada beberapa yang tidak teraspirasi, namun ternyata tetap saja bisa terjadi kejadian intravaskuler. Kemudian pertanyaan selanjutnya kita akan menanyakan mengenai aspirasi positif. Jika aspirasi positif, apakah harus berhenti atau tidak? So the next question, I'm still going to ask about positive aspiration. So if we found a positive aspiration, Prof. Galadari, should we stop the injection? Can we move to other areas or just stop right away?
No. If it's positive, you stop, and then you have to move to the other areas. Yeah. So, you just move to the other area and start injecting.
Oke, jadi thank you, Prof. Jadi untuk aspirasi positif kita harus berhenti melakukan tindakan filler di tempat yang tadi, tapi Anda bisa pindah ke tempat yang lain, melakukan entry point dari tempat yang lain juga. Kemudian kita akan menanyakan dari Dr. Yeli Anifianti. Professor Galadari, other than hyaluronidase for filler complications, she is asking about corticosteroids as one of the treatments for patients with vascular complications. So what is your opinion about the corticosteroids and the dosage?
So they're not recommended. I mean, you're not basically treating anything. If it's a vascular compromise, you know, the vascular compromise is caused by a physical filler that's in the blood vessel. So your corticosteroids are not going to do anything. Corticosteroids are going to be quite useful if you're dealing with inflammatory nodules, for example, and you know other things, but not for vascular compromise.
Oke, jadi untuk thank you Prof. Galadari. Jadi untuk kortikosteroid untuk komplikasi pembuluh darah itu ternyata menurut Prof tidak memiliki manfaat yang besar. Namun kortikosteroid dapat dipertimbangkan kegunaannya bila Anda menghadapi misalnya nodul-nodul inflamasi yang terjadi setelah penyuntikan filler. Okay, now we are going to next question. Next question is about from Dr. Laura Jessica Caban. She is asking about your experience to handle the complication treatment fillers from other physician. How far we can handle this condition and refer the patient to the physician that do the treatment, or we must immediately handle the condition? Like we refer back to the
So that's a good question. If a patient comes to you and they're, for example, having a nodule that was formed in the lips or the cheeks or anything, and they tell you for a fact that they've had a filler and they tell you filler X was injected, okay, and you know filler X, for example, is a hyaluronic acid filler, and they are 100% sure that this was the filler that was injected, treat them. If you treat them with a little bit of hyaluronidase, it goes away. You are going to be their favorite doctor. They will love you for it. Okay. If the patient, however, comes to you, they do not know what filler was injected, and you know, even after, you know, they don't know the filler, they call the clinic and the clinic refuses to tell them what the filler is. Anyway, in any case, the filler is unknown. Do not treat them, because if you treat them, the thing that you're going to be treating, you're probably going to be injecting hyaluronidase, because that's probably the most common thing. If it doesn't get any better, what's going to happen is that they're not going to remember Dr. X who injected them. They're going to remember you. You're the one who's trying to help them. But patients don't remember the original. They remember the one who's trying to, the last doctor who's helping them. So for example, if they go out in the supermarket and a person tells them, oh, what happened to your lip? Why is your lip so swollen? They will say, look, oh, I went to Dr. Galadari and this is how my lips look like. Okay, even though Dr. Galadari did not inject the lips, he was trying to help her lips. So here, if you are unaware of the filler, don't inject them and just refer them back to their doctor.
Okay, thank you. And then the next question from Dr. Tandiono Hermanda. Do you make an informed consent for handling the complications with hyaluronidase, and if the patient failure to be helped at all? And is there any reports about a patient that is failed being treated with hyaluronidase?
Usually no. I mean, if it's hyaluronidase, I mean, unless, you know, your hyaluronidase is either expired or there's something wrong with your hyaluronidase, or you're not using the right, you know, the right material, you know, the filler, if it's a hyaluronic acid filler, especially by the ones that are made by the major companies that are out there, it will dissolve. And you saw, I mean, the video that I showed you was Restylane that was basically being dissolved. So if hyaluronidase should definitely work, unless the filler is not a hyaluronic acid, then it may not work. But hyaluronidase is actually is quite useful, even, for example, if you have a complication that was done by calcium hydroxylapatite, they will still recommend you injecting hyaluronidase first to see if it works for such patients. So hyaluronidase, for me at least, is going to be the go-to gold standard when taking care of a vascular compromise problem caused by fillers.
Yeah. Thank you. Jadi untuk penggunaan hyaluronidase, jika memang fillernya adalah asam hyaluronat pasti akan dissolve. Jadi keberhasilannya untuk melarutkan asam hyaluronat akan berhasil dengan hyaluronides, kecuali jika fillernya itu bukanlah dari asam hyaluronat. Dan ini juga menjawab pertanyaan dari Dr. Dian Pratiwi yang menanyakan jika menggunakan jika ada tanda-tanda oklusi vaskuler akan mengalami resolusi ya jika memang fillernya adalah asam hyaluronat. Oke, jadi berikutnya akan ada salah satu dari peserta yang akan berinteraksi langsung dengan Profesor Galadari. Jadi betul ya Mbak Arti?
Ya, betul, Dok.
Ya.
Ya,
Okay,
Dr. Denny
Professor
sudah siap.
Galadari, we have one attendees that want to interact with you directly. So here's Dr. Denny Chandra. Dr. Denny Chandra, silahkan pertanyaannya.
Halo Teh Ina Jen.
Hai, apa kabar?
Baik. I'm very sorry I'm not very in a proper dress, a proper outfit. Okay, I have question, Professor. When we do injection for the temple, for the temporal area, when we do the gunshot, is there any limit for the CC that we use? And if we do the gunshot, can it fall down to the cheek? The filler fall down to the cheek after that? That's my first question. Sorry,
Okay.
I'm on my car actually. Okay.
Okay, yeah. So coming back to the question, yes, I mean, personally, my recommendation when it comes to filling up the temples is that I would not go anywhere between over 1.5 ml. I mean, if you require more than that, I would fractionate the treatment. I would ask the patient to come back and see me, for example, in a couple of weeks for me to re-inject them again. But anywhere between 1 to 1.5 on each side is going to be the maximum. If you are, now remember the other question, whether it goes down into the cheeks, if you are injecting where I just showed you where to inject, which is basically the superior aspect, very close to the temporal crest, it is not going to go down. The temporalis muscle is going to be holding it. It's going to be completely held together. It's not going to go down. However, if you are going to be injecting more on the deeper side towards the lower aspect here as compared to here, then yes. So if you're just over the zygoma, if you go quite deep, well, of course, that's the reason why it's not recommended to inject in this area here. There is a little small pocket between the fat compartments in which filler can dissipate downwards, and you can find it actually into the cheeks. So it's not recommended to inject it in the gunshot this way. So that's the reason why you have to inject it a little bit more on the superior side.
Okay, got it. And my second question is, if we have a necrosis case, what can we do topically for the wound?
That's good. So when it comes to treating care of the necrosis topically, that's a very good question. Do not let the area dry. Okay, a lot of patients will say, "Oh, my friend tells me keep it dry, let the air touch it. It will heal faster." No, the more moisture it is, the better for it to kind of heal faster. So my recommendation here, you would use something like any healing cream. Something like Cicaplast, or Ciclefate, or just regular petroleum jelly. I put a large amount of it, and then completely cover the area, and then you can also put a little bit of a band-aid there just to make sure that the moisture just stays there. So the more moist it is, the more medium for a proper wound healing that can happen.
Can we add some antibiotic ointment?
You can. It's not really overtly recommended, because remember, you do have sterile pustules that are forming over there. So but these are sterile. There's no growth that's happening. So just proper wound care is going to be more than enough. So you really don't have to give them antibiotics, because the area is not really truly infected.
Okay, one more for the wound. Should we do debridement?
What is that?
Debridement is we clean up the whole
sloughing necrosis area.
The sloughing, yeah.
No, so you mean how to clean it?
yes, should we really clean it, or we should just like
Oh.
regular handling the wound?
Okay. So I'm thinking of, so you probably mean debridement of the wound. If there's like any,
Yes.
now, hopefully you do not require debridement of the wound. I mean, if you're debriding the wound, that means the area is very large. Okay, and that will require debridement. Most of the time that if you have necrosis, especially with fillers, they're very small areas, whether they're presently around the lips, maybe around the nose. It does not require any major debridement, and just really normal topical wound care is more than enough, rather than debridement of the area.
Okay, then. I think that's all for my question, Dr. Jane. Thank you, Prof.
I gotta tell you, I
Yeah.
love your T-shirt.
Thanks.
I'm a big Batman fan, so that's really good.
Well, you can be an
I
actor
should
of
wear
Batman.
Batman cape.
I think it suits you. Okay, thank you so much.
Thank you.
Ya, terima kasih Dr. Denny sudah bersedia ini ya interaksi dengan kita.
Regenesis Open Education.